Welcome to The Exam Room with your host, Dr. Rhiannon Winsor. In this podcast, we explore how value-based care is transforming healthcare for the better. From probing today's challenges to charting innovative breakthroughs, we're here to dissect what's shaping the future of patient-centered healthcare. In this episode, we're exploring one of the most important and misunderstood transitions in modern medicine: the shift from fee-for-service to value-based care. What does it really mean for providers, patients, and health centers on the front lines, and why are more organizations looking to accountable care organizations, or ACOs, as strategic partners in this evolving landscape? To break it all down, Dr. Rhiannon Winsor sits down with Tony Rodgers, a seasoned leader in healthcare transformation, to unpack the differences between these payment models, the challenges of transitioning mindsets and systems, and the opportunities for creating better outcomes at lower cost. If you've ever wondered how we can move from volume to value in healthcare, or what it takes to truly care for patients holistically, this conversation is for you. Let's get into it.
Well, today we're going to examine some value-based care topics, some burning issues, and we're going to kick it off with a discussion about the difference between fee-for-service and value-based payment model. But before I do that, I have a question for you. So VB Care ABC Networks is an ACO, an accountable care organization, and we have health centers that have partnered with us. Why would a health center want to partner with an ACO?
Good question. So when I asked the board, because we have a board of federally qualified health centers who participate in our network, the common statement was that the reason we want to participate in our own ACO is we realize that value-based payment is the payment of the future. And it's better to get to understand the implications and how to be successful in value-based care and value-based payment early in the process versus waiting until it becomes the predominant payment by payers. And in particular for FQHCs, the two predominant payers are Medicaid and Medicare. And those two payers are moving aggressively in value-based care.
So what's the added incentive for the health centers to shift from this concept of fee-for-service, we know they still have to have it, into this mindset of value-based care?
Well, I think the biggest incentive is that they can earn money based on their performance, so they can get quality incentives, as well as earn money in terms of what we refer to as shared savings. So shared savings is a process where the payer determines a benchmark. And if you're under the benchmark, you get to receive a portion of the dollars you've saved. The benchmark is based on what the payer feels is the reasonable amount of medical expenditure for a population of patients, and that to drive healthcare costs down and reduce the inflationary factors in healthcare. It is believed that if you have an accountable provider, and that accountable provider takes responsibility for that patient population, that they could manage the patients better than just having a payer or a health plan. That the health plan is too far removed from the patient. That the accountable provider should be able to work with the patient and their family to come up with reasonable strategies to improve the outcomes over time. And that's the issue. In fee-for-service, it's all transactional. You come in for a service, you have a payer who pays on a fee, and then you're gone and the next patient comes in. In value-based care and value-based payment, the incentive is to take care of the patient holistically. And if you do that well, then you gain share with the health plan or the payer, the dollars that you save, or the improvement in value, which is the value is equated as quality and cost. So those two elements together achieve a value proposition for the patient. And the value of quality is based on outcomes that should be achieved long term. And the value of cost is the ability to manage the patient's cost over time below a benchmark.
So what I hear you saying is fee-for-service is the more patients I see as a provider, the more money I make. Value-based care isn't that way.
Right. It's the more you can control the medically necessary costs of a patient. Now, I will say this. If you tell this to most beneficiaries or patients, they're worried that, oh, you're going to cut my services. No, actually, the best way to manage service is to have someone who is looking at you holistically instead of as an individual organ, like, your heart or your liver or your lungs, but rather is looking at you holistically. And that's where primary care comes in, is that the payers are placing the burden, well, not the burden, but the accountability of managing the patient over time and being that navigator on the primary care provider. And if the primary care provider does well, they would get the incentive dollars that go along with it.
Mm-hmm. So how are the health centers doing with this paradigm shift from fee-for-service to value-based payment?
And that's a good question, because I think it's not a single answer. We have some health centers that are really doing much better. They have made the investment, and I believe they're beginning to see the benefit of those investments. We have some health centers who haven't been able to make the investment or have not been able to transition enough of their clinical services to a value-based approach. They're still very strong in the fee-for-service mindset. You have to appreciate fee-for-service has been around for 40 years, and it's been during the time that fee-for-service has been the predominant way to pay for services. Primary care has been marginalized. The rates that are paid to primary care providers were always so much lower than the rates paid to a specialist, as well as any effort on the primary care providers with the patient in terms of continuity or providing holistic care were not paid for in the fee-for-service system. So if you provided that service, it was on your, if you will, on your own time, on your own dime, so to speak. For example, telehealth is a relatively recent opportunity for providers. Making what's referred to as telephone calls to your patient to check up on them is relatively recent, that's being paid for. But it's still very strongly embedded in our health centers that they have to generate their operational revenues from fee-for-service. So if you have to push patients, I got to see 20 patients a day or 25 patients a day, how much time do you have to think about your patients when you're an employed physician and if you achieve your 20 patients a day? Well, I've done my job. I'm going home. I'm going to not think about it until tomorrow morning when I've come back, and then I'll deal with those patients. So there's no one thinking long-term about this patient, their needs, their situation. And this is especially a problem with high-risk patients, because if you don't do that, if you don't have a strategy, if you don't have a care plan, an individual care plan, then you're not working towards their future. You're just working towards what you can generate today from examination or treatment of the patient.
Right. Is it kind of like that 80-20 rule where 20% of the patients are generating 80% of the costs, and
Absolutely.
They need to focus on that. So with all of your experience and years of wisdom, what would you say health centers can do to get better at this?
It is a process. It starts with the executive. If the executive has not aligned his organization to understand the goals of value-based care, and why the organization needs to move in that direction. And if you don't see the executive leadership talking about it and expecting it from the performance of their clinical teams or the performance of their management in terms of how their role in value-based care, and if you don't use some of these new, what I call provider extenders, like community health workers and even medical assistants, in a new way to be connecting to their patients, you don't have care management processes, then you're not going to be successful. But if you're an executive, you have to ask the question, how am I going to fund this in the interim? And that is the dilemma for many of the health centers. The ones who have funded it are waiting until they begin to see a return on that investment. And how long can they keep funding extra staff and setting aside more time for their providers to create those relationships? That's their dilemma. And I think people start out with a lot of energy and they realize how hard this is. And our role as an ACO is to keep them focused on it and incrementally move them in that direction of value-based payment. I do think the strategy is start small, and build out. You cannot do this as a major effort across your entire system or all your satellite centers, et cetera. You have to build champions and demonstrate the effectiveness of this. The other part of value-based is the expectation of the patient. And in a fee-for-service system, patients have become used to just coming in for a particular problem and then go out the door. And the whole system has been set up that way, so you feel like you're just in a production line, right? With value-based, you need to raise the health literacy of your population so that the conversations you have from 6 months from now become much more engaged than the ones that you start out with. So those are some of the goals that you have to set, both expectations on the patient and the family, the caregiver, as well as expectations on the provider.
So I'm glad that you brought up care management systems, and I'm also glad that you brought up the patient education piece or health literacy of the patient, because here at VB Care ABC Network, we are working on a patient health education program, and we're also working on a chronic care management series for executive leadership. So it really sounds like there's education and learning, and open-mindedness is a big component of this too.
When you have a network, especially of health centers, you have to realize that value-based is very new to the staff and it's new to the providers. I wish that there was greater training on the value-based model in residency, because a lot of our health centers use people who have just come out of residency and they are hired for 2 years to get their loan repayment completed, and then they're gone. And so then you bring in the next group. And the problem with that is that those new physicians have never been trained in value-based. So that's not their mindset when they come in to work for a health center. And so we have to build tools for training of staff and providers, but we also have to have a channel to the patient. And I think our learning management system is an excellent platform for that. And I really want to see us pilot some innovative approaches to getting health education, to raise health literacy in our patient population, especially our high-risk population. Mm-hmm. You and I often hear stories about patients and how difficult it is for them to understand what's really happening to their body, what's really happening with their disease, even the medications they take, the side effects, etc. And the health system is, I would say in general, deaf to what patients' concerns are. Oh, we gave you the medication, just take it, every 3 hours. Oh, the medication does this to me, or I feel funny. And if you don't have an engaged provider, like a primary care provider, who can reassess the medications you're on, that could be a problem. I know my primary care provider, I'll tell you honestly, as a patient, as we all are, I interviewed my primary care provider, and I told my primary care provider when I first saw them, do you like me as a patient? Because if you don't like me, you're not going to want to see me. But if we get along as partners in my health, I will be more compliant and we can have conversations about what I can and cannot do. And I appreciate my primary care provider, who actually worked in a federally qualified health center, because he was very open to that. And I think a lot of times we accept the provider in front of us and, okay, person says this, out the door. My point with my primary care provider, this is a long-term relationship. And I do not want you kicking me out the door, if you will, but rather I want you thinking about me and all the issues. And, lo and behold, when we have conversations, we go and we look at the long-term strategies and the effects of certain chronic conditions I have upon my ability to work even. And, because I told them that's my goal. And the thing about value-based is it's built on two things. It's built on the goals of the patient and the outcomes the provider can achieve with that patient. And sometimes that outcome is to understand that the patient's terminal. And the conversation you have with the patient and their family is so important. When I was at CMS, one of the biggest issues I saw in the healthcare system, especially with certain states like Florida and Texas, etc., is at the end of life, everybody ended up in an ICU for 2 or 3 weeks, and they died. And I would love patients or anybody to see what happens to you in an ICU, how noisy it is, how uncomfortable it is. Even for the families, it can be kind of a daunting experience to go in, or in some cases you can't even go in because if you have COVID or if you potentially have COVID, etc., they're not going to let you in. But to the patient, it's very uncomfortable. And yet we believe keeping somebody alive for an extra day or an extra week, whatever, is the way it should be. Well, I'm sorry, that's not the way it should be. You should be comfortable in passing. We think that medicine's going to somehow have a miraculous effect on people. And the reason why I bring this up is because of the fee-for-service system, primary care providers are not prepared to have that conversation. They weren't trained for it, nor were they paid for it. And so, well, that's not my problem. That's the hospital's problem, or that's the ER problem. Well, what it's created is a situation where patients end up in the ICU instead of in hospice, which is a much more comfortable situation. Hospice at home, hospice facilities are a much better place to have that end-of-life experience because we all will have it. But you have to believe that you have a goal as you're transitioning to that. And what is your goal? Is it to be sitting in an ICU with tubes running down you and all that stuff? And then if you haven't got a do not resuscitate, they're going to try to resuscitate you, which can be a very painful experience. And so we have to change that mindset. And it just means the trust factor between the primary care provider and the patient and their family has to increase. And providers have to realize that's part of my responsibility, to help people transition at different stages of their life. It's a transition when you learn that you have a chronic condition. It's a transition when you learn you have cancer. It's a transition when you can't do what you used to do, right? But it's also a transition when you're at the point of end of life.
So developing and cultivating that relationship, that rapport with the patient is definitely a big component of value-based care.
Thank you for joining us in the exam room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation was as insightful as your last checkup. A big thank you to our guests for sharing their expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. Until next time, take care, and thanks for listening to The Exam Room.